morning, everybody. My name is Mary Guggenheim. I call to order this meeting of the Quality and Patient Safety Committee of the Cook County Health System. Pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. And in order to streamline proceedings, we shall combine the action items into one combined motion so that only one roll call vote will be needed during the meeting. And I also note that meetings of the Cook County Health Board and its committees will be held remotely until otherwise noticed, due to the determination that a public health emergency either exists or has recently existed. So Debbie, if you would call the roll, please, that would be helpful.
Director Garza. And serving as a substitute member, Director Ketting.
Present.
Director Prendergast is absent. Director Story.
Present.
Thank you. Chair Guggenheim.
Present.
And for the record, those directors or members also present, Director Harrington.
Present.
Thank you. And Ms. Merriweather.
Present.
Okay, you have a quorum.
Thank you. And I will just note that the next committee meeting of this Quality and Patient Safety Committee will be held on Thursday. Oh, wait. This says Thursday the 18th. That's not correct because today is the 18th of August. So it will be held on September. Do you have the date of that, Debbie?
1 second, pulling it up.
Sorry, it's the wrong date is here on my.
I didn't fix that. September 23rd.
Thank you. September 23rd, 10:30 a.m. for the next committee meeting. And is there any public testimony this morning?
We did not have any registered speakers.
Fine. In that case, we'll move on to reports on quality and patient safety matters, and the HRO dashboard, I believe, will be presented by Leslie Frayne, Associate Chief Quality Officer.
Yes. I'll go ahead and report out on our 5 metrics. First is our 30-day readmission rate. There was a slight increase in the readmission rate from 10 to 10.5 between March and April. Although this increase was seen, the increase of the 0.5% was basically seen in our trauma patients. However, this does align with the volumes of trauma patients that did go up in April during this time period, which is expected. Although the overall increase was observed, the readmission rate for heart failure patients actually fell to 5.5%. And this is the lowest readmission rate for Stroger for heart failure since we've been measuring it. So really kudos to the efforts of the readmission team led by Dr. Jabbar and Cassandra Waddington, and some of the tactics that are currently being worked on in the readmission work group on heart failure that have really led to and hopefully these things are, as we say, now being stuck in the mud per se, and consistent over time, and be able to see this sustainability. But what some of the tactics that they're doing and doing well on are the follow-up appointments. What they've changed is they're actually requesting these upon admission instead of waiting last minute at discharge, where everything's a bit of a scramble, and getting those appointments settled upon admission. And then also the follow-up appointments with the cardiologist within 7 days, not only making sure that they're made, but also making sure that the patients show up, and monitoring that. Also, I have a hand up. You have a question?
Yeah, month over month, this number bounces around. There's no real pattern here. And I'm wondering if we don't need some or could not benefit from some different analytics where we look at the returns on a more segmented way, where, and I was struck by your comment that, well, we see this among trauma patients, but that's not surprising because trauma patients went up. But when we lump trauma patients and heart failure patients together in the same measure, are we obscuring more than we're showing? So I don't expect an on-the-spot answer, but it strikes me it might be worthwhile thinking about, instead of one overall 30-day readmission rate, although I know that's what Medicare looks at, whether for our own management purposes, we could get more understanding of what's actually going on by segmenting the categories of readmission rate and look at it in that more sophisticated way. That's just something for you guys to think about.
No, and thank you for that. And we actually do break down this data even further into the specific DRGs in the readmission work group. For this purposes of the QPS board, we show just the overall for all the readmissions lumped into one bucket, but we actually do break it down further into the different DRGs. And again, the HRO readmission work group focused most of its efforts on heart failure with the plans of expanding that out into the other DRGs. So it's great to point that out.
Very fruitful kind of endeavor.
Yeah.
And there's probably a limit to the number of those we can do, either because there's not scale or staff resources. But
exactly.
By focusing more, it helps us understand better how you're thinking about addressing this issue of readmission. Right. We don't want readmissions if they're avoidable, but we should focus our efforts.
Great. Thank you for pointing that out. All right, and some of the other tactics that I was mentioning, the pharmacist consultation. We're making calls post-discharge. Actually, we're using 2 pharmacy students on a rotating basis. It's been very beneficial. Heart failure education. We're now educating the bedside nurses to also give education to the patients, not just the transition of care coaches, because that was a lot to take on. So educating the actual nurses taking care of the patients to give that education. And our transition of care coaches, or nurses, not coaches, now have Tiger Connect, which is making it easier for patients to communicate with them. So they're actually giving their number and entering it into patients' phones while they're admitted on their index admission. And then they're encouraging the patients to call them before going to the ED. So this will be very helpful for better communication, the transition of care nurse. Hopefully preventing an ED visit if it's something that can be, if it's not required to go to the ED, because that's also building up our excess days if just showing up in the ED. So those are many tactics that they're working on. And like I said, nice to hit that 5.5%, the lowest readmission for Stroger in heart failure. So again, kudos to the team. The next slide is our case mix index for medical MSDRG. This actually decreased between April and May. It fell to 1.189 from 1.222. And the increase you see there in January was attributed to the large volume of COVID patients. And as the number of COVID patients has decreased, the CMI has also shown a decline, which would be expected since COVID increases the CMI by actual 20%. The capture rate in medical DRG also declined between April and May slightly from 66 to 63% and performed just above the 25th percentile in comparable hospitals. Our next slide is our CMI for our surgical MSDRG. This decreased between April and May from 3.283 to 2.939. And we did not meet target or stretch goals or outperform the Vizient benchmark for comparable hospitals. That benchmark is 2.939, and we came in at 3.060, so just missed that. The capture rate for surgical DRG in May was 64% and performed just above the median in comparable hospitals. The CDI team continues to target specific service lines such as trauma, ICU, cardiology, and physician education and documentation, and also working with the CDIs. The CDI data from May that aligns with this, they did 98% concurrent review. That was their rate. They queried 211 physicians. They had a 95% response rate and a 94% agreement rate, which led to an approximately $870,000 financial impact and also really helps with increasing the CMI. The next slide is our top box score for recommending the hospital. This showed a decrease between May and June from 71.32 to 69%. And although the likelihood to recommend has slightly declined, the measures within the HCAHPS are actually showing improvement. Specifically, the questions around nurses have shown considerable improvement over the last 12 months. And it's also important to highlight that patient experience scores across the country are showing declines due to the impacts of COVID. While Stroger is showing a decline, the decreases are not at the same rate as national averages. And I believe it was last meeting, Director Keating, you asked about that spike in August. So we did look into that. Thank you, Tara Rulin, for looking into that and really putting the why behind that spike. And it really looks like that spike was mainly from the physician metrics with the support of a few other pieces. The communication with doctors is actually the highest performing category in HCAHPS survey for Stroger Hospital. So when the communication with doctors increases, you see the overall recommend the hospital increase. So from January to July, communications with doctors was in the 80th percentile against all Press Ganey hospitals. And this measure can influence the overall likelihood to recommend, as I just stated. So months where this measure tends to perform well, the likelihood to recommend also performs well. And then right around this time, also a new class of incoming residents starts in July. And the patient experience scores tend to have a slight increase in these months just after the start of the incoming residents. So patient comments also pulled from this time frame show patients increased numbers of patients reporting that the doctor showed concern for me and that my doctors made sure I understood what was happening and eased my concern. And they gave me details about my health. So all of these put together really impacted that increase in the overall, which were mostly related to the communication with doctors. So I hope that helps you understand that spike. Any questions about that?
Well, we'll see if it has explanatory power when the new residents start.
Right.
Although I shudder to think what the actual implications of that would be if it happens again.
So, Ms. Merriweather, did you have a question?
Yes, I do. And that's, how is the PFAC engaged in this process? And are they able to also provide input into how to improve the experience scores?
Well, we have had, I believe, our third PFAC, 2 or 3 now. And some of the input from the patients that we're getting at the PFAC was much about scheduling of appointments and things like that. And we have targeted specific interventions around the feedback received from them. Mm-hmm. And interestingly, I know the few patients that we have consistently said in the meetings that they come to Stroger for the doctors. They love the care from their doctors. It's the things about walking into the facility, finding their way around, and scheduling of appointments that we really have heard some more negative things around that, we're working on. And I don't know if Ling Dang is on this, but she's really been key in the follow-up from the PFAC committees as she's leading those.
Because I wonder if they see the scores, the information that we're seeing, and they can provide input into that.
No, I really don't believe we're not sharing these results at the PFAC.
I think it's important because again, I think they're invested already in improving the care. And if they know there's some targeted areas, they could also provide some input.
Excellent advice. Thank you. We have another question.
This is Director Herring. I was just really interested in the relationship of residents coming in and scores going up and them being new and maybe it picks up on Dr. Or Director Keating's. It'd be interesting to see if that's similar the next time residents come through, that there is this uptick and what possibly might cause there to be an uptick. And since you say that this score is more driven by the providers, the physicians, their interactions with patients. I don't know if on an ongoing basis or anytime we actually talk to the physicians about how important their conversations are with the patients and their work with the patients in terms of our patients' perception of the care they get relative to their other encounters in the institution.
Right. And as I stated, it's the communication with doctors has actually been the highest performing category in the HCAHPS for Stroger. So just that category is typically our highest performing. You know, we're absolutely working on nurse communication and all of the nursing tactics, which have also showed some improvements overall. So, but it's been the highest.
Thank you.
Sure. All right, next slide is our hemoglobin A1C greater than 9. This is for our patients that have a hemoglobin A1C greater than 9. This decreased to 25%, and this is showing actually over nearly 3.5% reduction this year. And as we all know, in care is at least 2 clinic visits within the 2 years. The goal is 24%, which reflects top decile performance. And with the continued improved performance, Stroger is actually closing in on the top decile performance. Some of the action items that the ambulatory clinics are working on, the sites since October actually have been all showing improvements in the HEDIS measure. They have developed an ambulatory, what we call triad, and that triad includes Dr. Irons, who's reported out here frequently with the HEDIS metrics, Beth Vaklovic, who's our ACNE for ambulatory, and Madi Ferreira, who's our quality improvement director for ambulatory. They have created this triad with them, and they've been leading the PI initiatives since March to actually improve all 5 of the HEDIS measures, which this one is included in. Also, clinic staff have developed current and future state process mapping and involving the frontline clinical level champions. And this has been very impactful. We've actually been working with a consultant who is a black belt in performance improvement and has been working consistently with all the clinic leaders over the past few months on their projects. A new restructured HEDIS steering committee was launched in June to include physician and operational champions, BI, HIS, and actually MCO leadership too. And the physician and operational leads have created monthly report outs of current data and action plans to the HEDIS steering committee. Some of the next steps include meeting with the clinical dyad leaderships to strategize implementation efforts within pilot sites for each measure. And the A&E, Beth is working to identify nurse team leads to provide support and oversight of the new workflows. So the triad leadership will be participating in on-site visits for coaching and support of the new workflows next month. Next slide is our data definitions. Any other questions?
Yes, I have a question. I know we're not using the pediatric immunization rates as one of our measures that we report on regularly, but in view of this alarming resurgence of polio that apparently has emerged as a new public health problem, I wonder if we could get a report next time on how we're doing on those childhood immunization statistics, or indeed if anybody on the call has any information about this, I think it would be interesting to hear about it.
Is there anyone on the call that could speak to that? If not, I will bring it back to next month's meeting.
This is Mark Lopeman, Family Medicine. We're obviously looking at it and doing some media. We're getting quite a few media requests for information around it. And I think right now that we have a high uptake of polio. It's not one that any of our patients typically are concerned about. So it's widely accepted and given. The concern, of course, is for those kids that are out of care and don't have that. So it's an area that we're looking at reaching out for folks and seeing. When we have reached out to our kids that are out of care, we often find they are in care somewhere else, and that's an important piece to close. The second part quickly is just, when will a booster dose be recommended for everybody who is up to date, but those who may be at risk, those with certain types of immunodeficiency are considered at risk of developing the paralyzing complications of polio, and certainly all children are a risk population. So I think we're waiting for guidance from CDC on when and if a booster would be eligible, and certainly if any polio is picked up in the wastewater in our area, then that may start rolling out. So it's something we're actively watching.
Right, thank you. That's good to know. I think there are a couple of other questions. Mike, do you have a question?
Yeah, well, yeah, I guess. This may raise a jurisdictional issue, but I think it's really important to remember that the county care is, in theory, managing the care for a ton of kids in Cook County. And we should make sure that they are keeping on top of this too. I think they are, because I raised the question and others raised the question, but we really see more kids through county care than we do in our own clinics. So we have to, we're responsible for more kids. We don't actually see them. So there may be a jurisdictional issue here at the board level, but it's really important for us to exercise our role as a managed care organization.
Right. Good point. And Director Harrington, you have a question too?
Well, I was wondering if there is a government agency like the CDC that actually collects vaccine information and knows by state or by region who's at what percentage of children are actually immunized. I mean, I've heard reports of immunization levels, and so I'm sure that that's something that's reportable, probably to CDC, and they may be sharing that information with the state.
Level, isn't it?
Pardon me?
The state collects those data.
Well, I'm sure. I don't know. That's state. Maybe I'll defer to Ms. Merriweather, because she seems like she may have an answer. But I know that we collect a lot of data, and some of it is not publicly reported. But I assume that that's data that's being collected, and someone has an idea of the vaccination levels in the state of Illinois, and probably by county and possibly city.
The CDC did announce today that vaccination levels for polio were about at 92% nationwide. But about a year ago, the Blue Cross Blue Shield Association did release a report on immunizations, childhood immunizations, and across the nation for their population, it had dropped to about 88%. And 86% is what they view as the herd immunity that needs to occur. I work with Rotary quite a bit, and Rotary is part of the Global Polio Initiative. And there was a meeting last week on this very issue of New York and also London, and the importance of vigilance in terms of looking at the waste systems and making sure that people are collecting the information, because it could spread easily among the unvaccinated. So
Right.
it's It's a
Right.
dangerous condition, and we're also seeing many people that had polio as a child, almost like with the COVID long-term. There's polio syndrome, and they're putting out education on the polio syndrome for clinicians as well. So I do think there's a concern. It's not a panic, but it is a great deal of concern.
Right. And then there's the influx of refugees that we've had recently in parts of the world where sort of turmoil probably has interrupted vaccination efforts, I assume.
Yes, if they're coming to the US, they typically do quite a bit of vaccinations as they enter the US, but yes, they can come unvaccinated. But I do know that clinicians have set up office hours to make sure the immigrants are getting vaccinated, the refugees, but it is a concern worldwide.
And I believe there's another question.
Hello, everyone. This is Madi Ferrer, Director of Quality for Ambulatory. In reference to the previous question, we do have iCare, which stands for Illinois Comprehensive Automated Immunization Registry Exchange. It's a web-based immunization record sharing application by IDPH. It allows us to share immunization records with Illinois residents. And there's a lot of features with that, which we use in every clinic.
Right, thank you.
Director Guggenheim, if I could add to that, to what Ms. Barrett just mentioned, that would be an excellent public health endeavor for us, because when we do have children that are out of care in our system, if staff take the time to pull up iCare, we can see if they've got vaccines somewhere else and get their record updated. But of course, that's an extra curricular workflow that we aren't staffed to do right now. But I think it would be particularly helpful to be able to do that. We could find then for our patients we're the primary care for assigned to us. I would imagine county care would the director's comments would want to be doing the same thing. So, because then at least we can see that we may see that they weren't vaccinated, but they were vaccinated. We can take them off the list for outreach and then target instead simply on those who iCare says they aren't vaccinated. Those would be the higher risk people to outreach. But again, this would be a public health staffed activity that we would love to have, but we don't have that as part of our workflow today. So that's a gap, I think, that we could consider addressing.
Right.
Yeah, I just have a comment, and just based on the discussion, it's saying that there's an opportunity for us to be proactive around what we're hearing, and whatever steps we need to take to be proactive, I would recommend we take.
Good. Any other questions on this dashboard report? If not, Leslie, I believe you're going to update us on regulatory and accreditation matters. Go ahead.
So, as far as regulatory updates for follow-up, there is no follow-up. I think I reported out last time for CAP, and everything was accepted. And listed here are our pending surveys. Our stroke, we're expecting actually pretty soon. This stroke survey, we actually get notified by Joint Commission the date that they're coming. So we are going to be doing another mock survey very soon. And then we have the Joint Commission extension survey for our MRI at Provident, and then Belmont-Crangan extension survey, and then Stroger trauma designation survey. When we are ready for that, we will put in for that. That's, voluntarily. So it's not like there's someone showing up. We're going to let them know when we're ready. We started preparing in last February. It's a lot of work, a lot of things to do. So we want to make sure we're ready. So that date is really undetermined at this point.
Okay, thank you. And now I believe we're going to have an update on the Heart Institute service line. Dr.
Guggenheim, can I just give just two position updates within the quality infrastructure?
Right.
I wanted to formally thank Tara, who's our Director of Planning Analysis. Unfortunately, Tara is leaving Cook County Health, going on to a new adventure. But I just wanted to formally thank you for all of her work. She's absolutely behind all of the data. She's a data science expert, and she has really been key in moving Cook County Health in the right direction in quality. So I wanted to formally thank her and let the committee know that she will be leaving us. So thank you, Tara.
Oh, that's going to be a big loss. I hope we're going to replace her, are we?
Yes. We will have to, I don't know if she's replaceable, but we will definitely replace the position.
Right.
And
Right.
well,
Yes,
I also
and
wanted
my
to,
thanks, because she's done a phenomenal job for us. Yeah.
thank you, Chair. And I also wanted to inform the committee that we will be having a new Chief Quality Officer starting with us in mid-September. His name is Dr. Eric Makaitis, and he's coming to us from the Franciscan Health System in Indiana. So we're excited to have him coming on board.
Thank you.
Thank you.
Good. All right, Dr. Dookie, it's all yours.
Good morning, everyone. I don't know if you can see my slides.
We can.
Okay. My name is Rami Dookie. I'm the Chief of Cardiology, and I'm struggling here with my slides a little bit. Just bear with me. We have too many screens and they're not cooperating. My computer froze. Bear with me for a second. Okay. My name is Rami Dookie. I'm the Chief of Cardiology. And I just wanted to update you a little bit about the Heart Institute. A few months ago, Cook County Health launched the Change Institute, which really targets elimination or closing the gap on health equity relating to cardiovascular diseases, stroke, cancer, and diabetes. And shortly after that, Cook County Health announced 3 new service lines: the Heart Institute, Neurosciences Service Line, and Cancer Center, which basically really in an attempt to bridge the gap in health, healthcare and health inequities relating to these very important health risks. I am delighted to be leading the effort to form the Heart Institute. And as far as our scope of the Heart Institute is basically to develop a comprehensive academic, world-class, equitable cardiac care program that spans from prevention all the way to most complex heart diseases. And what we're set out to do is basically build new clinical services that we lacked at Cook County Health to bridge this gap, align clinical disciplines that's involved in cardiac care outside the division of cardiology, and build quality not only to provide services, but also to provide highest care possible. And as you can imagine, this is a fairly complex task that involves a number of departments and divisions, not only from cardiology, but also cardiac surgery, anesthesiology, radiology, nursing, administration, operations, and others. And we basically set out a complex organizational structure that captures leadership from variety of disciplines and subspecialties within cardiology, cardiac care, imaging, and others, and put them all under one umbrella in a leadership council. And the entire institute will be led by an executive council, to make executive decisions, moving the institute forward. In addition to those, there are other things that the institute would touch, and I don't want to belabor this, but there are numerous aspects of the health system would interface with the Heart Institute in a variety of ways. And we set out for us short-term goals, which is basically building comprehensive cardiac care program, essentially, creating service lines that we did not have previously, particularly high revenue cardiac services that help us not only provide the care, but also hopefully provide the healthy finances for the program. And also important for us, address the immediate health inequities in heart diseases in our health system and the population we serve. And the long term, we aim to elevate quality, reputation, and the academic stature of our program and grow our market share when it comes to heart diseases. In recent years, we have a few accomplishments, such as creating the Heart Team, which is a clinical team of cardiology, cardiac surgeons, occasionally anesthesiologists, that address every patient in a multidisciplinary format, make multidisciplinary decisions in the inpatient side, in the clinic where we have cardiac surgery and cardiology have clinics running together in the same space and time and in close collaboration, and also a conference that we discuss cases that can go either way. We built a new structural heart disease interventions program, which I'm going to touch on in a second. We built a new service line of electrophysiology, which we never had. We used to send all our patients to Rush and other institutions. We built a pulmonary embolism response team, which is a kind of a dedicated team, multidisciplinary team to address patients with pulmonary embolism, which is a life-threatening condition in the inpatient side. We built a heart failure service line, which we continues to build on. And we built also multi-modality cardiac imaging team in partnership between cardiology and radiology. I'm going to touch in on some of these issues. So these are the service lines, the high revenue service lines that we built to bridge some of the gaps in health inequities. These are, largely procedures that, often not offered to patients who lack financial resources or health insurance. We launched these in recent months. I'm not going to belabor these, but these are, advanced procedures, mostly transcatheter procedures, meaning they're not through open heart surgery or open surgeries, mostly done through catheters, typically approaching from the groin into the vascular system. I'm going to touch on a few highlights of these. The transcatheter aortic valve replacement. Historically, valve replacement, the aortic valve replacement done through surgery, as shown in this, this drawing here, basically involved opening the chest and replacing the valve. In recent year, I would say in the past decade or so, a procedure called TAVR, or transcatheter aortic valve replacement, allow us to replace the valve through basically a puncture through the groin, a big artery in the upper part of the thigh, and replace the valve inside, basically deploy a valve inside the old valve and push the old valve to the side. It was a big undertaking that involved a lot of preparation. And importantly, this allowed us to bridge the health inequity when it comes to this condition. Again, this is rarely offered even by most responsible health system to uninsured patients. We were able to offer it to insured and uninsured patients in a financially responsible way. We launched it in August of last year. Now we are, this number already needs updating. We've done a couple cases since I prepared these slides. We've done the most complex cases. And since we launched this procedure, we had zero referral outside our system into other hospitals. And this is something our team is very proud of. And again, this is a very big multidisciplinary team, as you see here, from nurses to technicians to physicians, interventionalists, cardiac surgeon, anesthesiologists, and others that have been involved in this, mid-level providers and others. We report our data publicly in a registry called the TVT registry, which is mandated by CMS. Opportunities in this is basically increasing our volume, improving our billing cycle, which we're watching very closely. Marketing we could use to bring more patients here, and we need an additional cath lab. Right now we have only 2 laboratories that are overbooked. We need to to build a third lab, which is in our planning, but this is going to take a little bit of time. Nursing and technical staff are in short supply these days, just nationally, but particularly at Cook County. We also launched the electrophysiology service line. Again, this allowed us to provide these critical procedures that basically treat cardiac arrhythmias, and then now we can offer it to all our patients, insured and uninsured. Prior to this, we used to send all our patients to Rush and other institutions, and since then we have had zero referral outside our system since November of 2021 when we launched the system. We're doing very well as far as projections. We are beating our projections by about 30%. We performed well over 100 ablations already, and we are on good footing with that. Again, opportunities, we need additional laboratory to accommodate these procedures. Again, nursing and technical staff remains a chronic problem for us. Billing cycle always needs close monitoring and making sure that we are getting reimbursed fairly for these procedures, and marketing something we can use again to increase our market share. The PERT program, which is the pulmonary embolism treatment team, again, this is multidisciplinary from cardiology, pulmonary medicine, emergency department, and cardiac surgery. Again, these are procedures typically not offered to patients who are not well insured. We were able to offer it to all our patients, and we launched this in November last year. And in terms of volume, we are at actually twice the projected volume so far. We had excellent procedural success so far. Again, we can use marketing, maybe drive some patients from neighboring hospitals through our doors. And again, staffing is an issue. STEMI or heart attack, we are a STEMI receiving center, and at Stroger Hospital, we have a STEMI QPS committee led by Dr. Yarab, actually, who joined me as director of our cath lab, and she joined us in this meeting. This is a multidisciplinary QPS committee from cardiology, emergency medicine, nursing staff, and others. Actually, we are slightly below the national average. We are in dark blue here for last year than the rest of the country in terms of readmission for patients presenting to us with heart attack. We've been recognized by the U.S. News and World Report and the American Heart Association as high-performing center for heart attack. As far as heart failure, we have put great effort to bring patients being discharged, just kind of dovetailing on what Ms. Frayne has presented earlier, to get patients discharged from the hospital with heart failure admissions into cardiology clinics. We formed a number of avenues for them to see our providers. The Heart Failure Continuity Clinic, which is provided by advanced practice provider. We have advanced heart failure clinic staffed by heart failure experts. All our physicians add clinic sessions after being on service to absorb all patients being discharged, namely heart failure. And we created a scheduling intervention along with the HRO team in partnership with HRO team to bring all these patients within 7 days of their admission to see a cardiologist or a cardiology provider. We're glad to report that since this intervention, so blue is before the intervention and orange after the intervention, we've been able to schedule 100% of the patient presenting with a certain aspect of heart failure in our clinic, heart failure with reduced ejection fraction, versus about 70% prior to our intervention. Not only this, we've been able to give the patients their appointment before they leave the hospital in 95% of the time versus 86% of the time prior to this intervention. This intervention involved looking at every admission, identifying a provider who would be most suitable to take care of the patient, communicate that with the treating team. So these appointments will come out on their discharge instructions, so the patient knows exactly where and when to come to clinic. This led to a marked increase in our show rate after discharge from 24% prior to the intervention to 71% after the intervention. I like to think this have participated in reducing hospital readmission, which Ms. Frayne has reported earlier. We're actually well below the national average as far as heart failure readmission. We are in the top quartile when it comes to 30-day readmission, and top decile when it comes to 7-day readmission. And again, we're recognized by U.S. News and World Report and American Heart Association as high-performing centers for the care of patients with heart failure. I want to share with you something about outpatient access into cardiology services. We provide not only access to general cardiology and cardiac surgery as part of the Heart Institute, but also a number of subspecialty within cardiology, not only heart failure, but also palliative care for patients who are at the end of the road when it comes to heart disease. We provide palliative counseling and potentially hospice care if that is appropriate. And we created a number of subspecialties within cardiology in the outpatient side, from structural heart disease, complex lipid disorders, electrophysiology, device clinic, cardiovascular genetics, cardio-oncology, HIV cardiology provided at the core center. These are subspecialties within cardiologists, usually provided only in university settings, and we've been able to provide these services to our patients in recent years. We provide cardiology services not only at Stroger, but also at Provident or SingStack Clinic, Blue Island. Our cardiologists go to Cermak Health Center and provide cardiology care over there rather than bringing the patients here. And we also provide cardiology care in the core center for patients with HIV and heart disease related to HIV or its treatments. We are considering adding locations for cardiology in one or more of community centers at North Riverside, Arlington Heights, and Belmont Cragen in consideration for adding cardiology services. As far as outpatient access, equity is a big consideration of ours. All our patients are provided with equitable access to our clinics. We provide subspecialty cares that's often not provided outside university settings. We do direct scheduling. We don't go through central scheduling. All clerks in the outpatient setting have access directly to our books and schedule patients directly, so patients leave primary care physician with an exact appointment for their cardiology provider. We increase access post-hospitalizations. As I said earlier, we provide 5 locations, Monday through Friday, morning and afternoon, all week long, we are there. Our third available for general cardiology is 1 to 7 days, depending on when you query the system. This is actually, it's based on the market standard. This is actually outstanding. We decrease our cycle length, meaning the patient, time from hitting our doors in the clinic to leaving over the past couple of years from 140 minutes to 95 minutes. And our show rate have increased from about 69% to over 77% over the past few years. Our volumes have been steadily increasing with the exception of a little dip in 2020 with COVID. But year after year, we've been increasing by about 10% to 11% in average. Between 2022 and 2016, we increased our outpatient volume by about 80%. We need a larger clinic space to see more patients. Actually, we are plateauing because of that. We just can't add sessions because of lack of rooms and lack of staff. So this is something an opportunity to improve our throughput. We have a very, quite advanced non-invasive laboratory. We offer echocardiography and stress testing in 3 locations, Stroger, Blue Island, and Provident. And we are accredited by Intersocietal Accreditation Commission as high-performing laboratories since 2019. We have opportunity to increase volume of provided to basically meet the demands of our patients. We need to recruit technologists to increase our volumes. And this year, it's an accreditation year actually in our cycle in 2022. We are adding Provident and Blue Island to our accreditation certificate. So hopefully we'll get those accredited also in 2022. We would like to offer more of these services in other neighborhood clinics to be closer to the patients. We are in the process of, our providers are engaged on a system-wide level in number of committees that touches patient care from or quality of care, from the Medical Oversight Committee, Critical Care Committee, STEMI Committee, PNT Committee, the IRB, and research integrity. There are a number of our providers involved in all these functions. Ongoing projects. One is building a cardiac imaging team. This is in partnership in terms of leadership and operation between cardiology and radiology. We recently added cardiac CT offering to Blue Island, and we are in the process of implementing a cardiovascular information system that provide wide access to imaging information throughout our system. We would like to improve access where we're hindered by technologist shortage and camera time availability for these modalities. And we would like to modernize some of our equipment, and we would like to get accredited by IAC for these kind of services. We're planning to launch a cardiology floor, which is a specialty inpatient floor in January of 2023 to provide higher level of care that is somewhere between general floor and a critical care unit. And this would be a 13-bed floor with a vision to expand to 20. The idea is to provide high level of care, reduce length of stay, and decrease unnecessary inpatient testing. And this will help increase actually the productivity of our cardiologists. We're in the process of forming a QPS committee for the Heart Institute, which is going to be led by Dr. Yaraf, who's actually with us in this meeting. That involves cardiology, cardiac surgery, radiology, nursing, and data managers. We're creating a dashboard along with our BI team to track our volume, quality, and financial data. And we would like to seek accreditation for imaging, as I mentioned earlier, but also the Joint Commission as a comprehensive heart attack center and a comprehensive cardiac care center. To build all these, we would like, as I said, initially we're working on building our quality, improve patient experience, build capacity in the outpatient side and in imaging, invest in Provident with the recent expansion, and we need marketing. We need to build research and academic stature. And for these needs, we put number of requests in the budget 2023. We would hope to, with appropriate allocation, we'll be able to build up these capacities. These are our opportunities to take us where we need to be. We need additional cath lab. We need larger clinic space so we can grow. We need to increase our access to imaging. We need to have increased access to anesthesia services as we grow our volumes. We need to build a cardiac rehab program, which is something we lack. And actually, this is an inequity issue for our patients. We need to create referral pipelines from neighboring hospitals so we can take care of complex patients presenting to neighboring hospitals. And we would like to expand our services at Providence so we minimize transfers to Stroger. We need to build an ECMO program, which is something for patients with advanced heart failure and cardiogenic shock. That, again, allows us to keep more of our patients here and accept more complex patients transferred here. We need to expedite our contracting and recruitment processes so we can build faster. And as I said earlier, we need more marketing to highlight the good work we do. I just want to highlight numerous champions of the Heart Institute, namely Mr. Rocha, Dr. Fagan, Ms. Eliana Mora, Ms. Gibson, Dr. Kumapli, Ms. Stanek, and Josh Ablis, who's been, helped us with project management. All these has been great advocate and champions for the Heart Institute, in addition to numerous leaders in Department of Medicine, cardiac surgery, radiology, and others, anesthesiology, ACHN, HR, and numerous others. So I want to thank them all, and I hope I did not forget many. And I would love to take any questions you may have.
I have a quick question. You talked about palliative care, cardiology. Do you have any plans to do any VADs as destination therapy? Since I know we don't do bridge to transplant, but VAD is destination therapy. I'm just curious if that's going to be in your quiver down the road.
Okay, I do not think we are in a position to implant VAD in our hospital yet. But we are in a position in September. Actually, we will be joined by a heart failure specialist, Dr. Demori. She's joining us coming from Florida, and she's going to start hopefully next month. Actually, she is on the agenda for you to approve her privileges. So hopefully she will join us next month. And with that, we'll be able to care for LVAD implanted elsewhere. We can do what's called shared care, where we can, patients implanted elsewhere, we can follow them up here. We have planned to start Impella program, which is a kind of temporary LVAD for sick patients in a bridge to transplant or recovery. But we do not plan on implanting LVAD. I would say in the next 3 to 5 years, we are not in a position to do that. But when we put all these building blocks here, destination LVAD may be something to think about in 3 to 5 years.
Thank you.
Thank you.
Yes, I think there's some other questions.
All right.
Ms. Merriweather, go ahead.
I just want to congratulate you for such a comprehensive, and the entire team for such a comprehensive approach to bringing equity to the community and providing the services. Again, a tremendous undertaking, but of great value to the residents and families in the community. So thank you, and thank the team for everything they've done to pull this together. It's really very, very comprehensive, well-structured, and now implementation. So thank you.
Thank you.
I think there were some other questions, but my screen doesn't tell me who it was. Oh, Director Story, have you got a question?
Thank you. Not a question. I just want to compliment. I thought it was also, just piggyback on Pat's comment, an excellent presentation. Looking forward to working with you and the team over the next several months and years, and would love to see the capital requests going forward so that we as a board could be prepared to support you in terms of the capital needs to stand up such a comprehensive but deserving and needed program in the community. So thank you once again for such a comprehensive presentation.
Thank you.
Thank you.
Director Harrington.
Yes, I want to commend you as well. I'm really excited to hear what you're doing and what you're proposing to do moving forward. And like Director Story, will support the funding for this initiative moving forward. Mine is really more an observation and perhaps a request. I have a unique background, having worked for both the city and state health departments. I spent about half my career working in public health. Also, the other half of my career, I worked at 3 different hospitals in the Chicago area. And there's a major difference between disease prevention and management of disease. And healthcare is really more involved in the management of disease. And we have a public health department, which is really focused on prevention of disease. And what we know in terms of both heart disease and cancer, some of the leading avoidable risk factors are smoking, obesity, and lack of physical activity. And so as we move along this path, I would strongly urge some discussion with the public health department to see what intersect there is between the work that you're doing, more so on the back end, and the work they're trying to do on the front end. And where is there an opportunity to collaborate moving forward, somewhere in the middle, so that we can prevent more people, although that may be not financially rewarding to you, from being in the hospital, suffering from these heart conditions, as opposed to creating environments where people are less likely to develop the kinds of morbidity and mortality they do over time. That's my observation.
100%. Prevention is key. 80% of heart diseases potentially are preventable. Among our plans actually is building prevention centers, not only at Struger, but also in the community in collaboration with Division of Endocrinology. They have lifestyle centers that we can potentially tap into. But also among our requests for budget 2023, smoking cessation counseling, dietitians. We'd like to build cardiac rehab program, which is also usually part of a secondary prevention program. So all these things are on our menu of things that we would like to do in the coming years.
Yeah, but public health is already doing
Absolutely.
work around healthy food, tobacco
100%.
cessation and.
We'll take note
and
of that.
so
Absolutely.
We really
Thank you.
need to make sure that our work is in sync.
100%.
Sure. In fact, this weekend, we connected Dr. Hasbrook with the cardiac service line team. We have a program that the board has been supportive of, which are the national updates that come from the advisory board. And they do a thorough review of trends, where it's happening, what services in alignment with community spread propensity prevention strategies. So we have set up a meeting already that is in motion for our public health department to start coordinating with our service lines. And that is part of what the Change Institute brings together. So it's part of the vision. We will make sure to update on how they're communicating together and working forward. And that is in motion as we speak right now.
Thank you.
Director Ketting.
Yeah, I just want to sing amen to Joe's comments, that we're not just a provider of healthcare, we are a public health system, and we have 400,000 people in county care. And I think it would be useful for the administration to think about what are some comparable kinds of measures that they can report to the board on with regard to prevention in heart care and other places, because we often don't give them as much attention because they're diffuse and really hard to get your hands around. In the meantime, great work. While we're waiting for prevention to kick in, let's make sure we're equitable on the cures we know are out there. So good work.
And
let's just broaden our focus.
Thank you.
The only thing I would add, I don't want to let the cat out of the bag too early, but I can tell you that we have been working with Dr. Hasbrook on a new exciting project that they're doing that would combine actually the data elements in the suburban territory and the city territory align with the work that we are doing. So I can just tell you that that has been underway. You've actually approved one of the components on it on one of the data programs that is coming forward already, and we hope to be able to have a full presentation for you on how that will coordinate in the weeks ahead. But he is working on it, and I think you're going to be very excited about the integration of how we're going to operate clinically with the data that is happening throughout the community surveillance.
Okay. Any other comments? No. All right. Let's move on to action items. And I believe, Dr. Kumaple, you're going to present the candidate for the division chair of general internal medicine.
Yes. Good morning, Chair Guggenheim and directors. I'm respectfully requesting approval of an initial appointment of Dr. Ina Mahapatra in the role of division chair of general internal medicine for an initial 2-year term from the 18th of August 2022 to the 17th of August 2024. Dr. Ina Mahapatra, after graduating medical school in India in '96, came to the US for her internship and residency program from 2002 to 2005. She did her training right here and subsequently joined our division of general internal medicine as a clinician educator attending physician in the division of general internal medicine. She quickly got involved in quality improvement and was extensively either involved or led several projects, which are too numerous to list. To further her education, she went on and obtained a master's in clinical research in 2010 from Rush University. Dr. Mahapatra took on progressive leadership roles over the years, including leading a multi-departmental task force for safe opioid and chronic pain management. For her work, she was recognized on the national level by the American College of Physicians as a quality improvement champion and won an award on April 20th, 2018. She also served from 2009 to 2020 as the medical director of our colon cancer screening clinics, standardizing colon cancer screening across all our ACHN clinics. And for the longer serving members of the Cook County Health Board, you may recognize the name Dr. Ina Mahapatra because the Cook County Board of Directors recognized her on August 26, 2016 for her efforts with standardizing the care of colon cancer screening. During our COVID pandemic, she was also very instrumental in spearheading outpatient efforts. Now, I must say after a national search and the interview process, it wasn't surprising to me that she was unanimously selected by the search group to take on this position of the incoming chair of the Division of General and Internal Medicine, an extremely important division where the majority of our primary care physicians reside and work mainly in our outpatient clinic. I will take any questions you may have.
Okay, any questions? I would ask that maybe when the minutes are forwarded to the board, that we include at least a brief paragraph about her previous experience, since this is such a key position in the general internal medicine division. So it would be interesting, I think, for the other directors to hear what you've just told us. So thank you very much for that. Now we proceed to the executive medical staff reports and recommendations. Dr. Akintorin.
Yes, good morning, Chair Guggenheim and directors. I'm presenting for your consideration the reports of John Stroger Hospital Credentials Committee. It's the report of medical staff appointments, reappointments, resignations, and retirements for the month of July 2022. Also, I'll give just a brief report or highlights of the summary of the HQIPS committee report for the month of, this was for the meeting that was held in June. So some highlights from that, the summary, that there has been a significant reduction in safety events. As of March 22, 2022, there were 9 of such safety events reported in comparison to 59 in the year 2021, March of 2021, which is a huge improvement. And also another item that I will respectfully highlight is the work of our hospital system in reduction of sepsis, mortality from sepsis. We are tracking and training compliance with sepsis bundle measures to improve outcomes of all our sepsis patients. We're not presenting any action items to the KPS committee today, as there were no action items regarding the HQIPS report to the EMS committee. Thank you.
Thank
I will take any questions. Thank you.
Ms. Merriweather, did you have your hand up, or was that?
Yes, I did. I just want to reiterate something I said before, is the challenge with sepsis. You can do the bundles is in many it's really what occurs in the outpatient. I shouldn't say outpatient, but in the setting as the patient leaves the hospital, or how long it takes for them to enter into the healthcare system in terms of hospital system. I have to say education and communication with the community for anyone that has an infection or leaves the hospital after having an infection really is critical. And it's not just a healthcare acquired infection, it's an infection that they entered the hospital with. So again, just want to reiterate, our biggest challenge with sepsis is making sure people get in time so that the bundles can be effective.
Okay, thank you for that. And now, if there are no other questions, Dr. Loafman, you're going to present on behalf of Provident, I believe.
Yes, thank you, Director. A few highlights I wanted to share are just HIS in terms of health information. There continues to be very high compliance at Provident, approaching 100% for timely H&P and discharge summaries being completed, and that continues on with the team health folks that are doing inpatient care now. Stack primary care saw some increases in their top box scores, again related to improvements in teamwork, and continues to be general support for provider and physician communication. So that's there. The VTE prophylaxis venous thromboembolism continues to be 100% on our inpatient side. Our pharmacy is watching that as well, along with anticoagulation use that's at 100%. Outpatient pharmacy, working on their wait time. Their goal is 30 minutes. It's still running over 60 minutes. There are several physical plant barriers, some staff and transition issues for that. We're looking at opportunities to improve that. One of the challenges that we find is that refills are managed by mail order, which is cost-effective and efficient, but of course they can't be available at the day of the visit. So if someone visits campus that day and gets refills placed, they won't be available at the time. So a few opportunities for improvement, but overall progress there. We also heard from patient access, care coordination, environment of care, behavioral health lab, and diagnostic imaging. And overall, we saw good reports and positive progress there. The quality team's working with all the folks at Providence to try to tweak and adjust measures for the coming year, putting some stretch goals in, especially as we look at expanding services at Providence, really trying to be sure that our service lines are ready to step up to the game. So lots of good work happening, and we'll have more to report. Thank you.
Thank you. And you're also presenting the recommendations for appointments and reappointments, yes?
I believe that's true, and I think that's in the credentialing packet there. So there's a variety of reappointments and some new providers coming on staff. All went through the credentialing process at Provident and were approved by Provident EMS and are forwarded to you for your review and final approval.
Fine, thank you. And the final item under action items is, I refer you to the minutes of the July meeting, which have been approved by the board at its July meeting, and they are presented for the committee's review and discussion. If anybody has any comment or correction to suggest, now is the time to do that. And hearing none, I will ask for someone to move the combined motion, which is to approve item 4A, the Stroger Hospital Division Chair initial appointment, to approve item 4B, Stroger Hospital medical staff appointments, reappointments and changes, approve item 4B, the Provident Hospital medical staff appointments, reappointments and changes, and to yes. Sorry, and am I getting it? Oh, okay. And the Quality Patient Safety Committee meeting minutes. And do I have a
This is Director Garza. I'll make the motion.
And is that seconded?
And Chair Guggenheim, just to be here, please mute. If you're not speaking, can you please mute? Okay, sorry, there was an echo. Director Garza is present, and so your quorum consists of you, Director Garza, and Director Story. So we don't have Director Ketting filling in as a substitute.
Okay.
And so that was moved by Director Garza and seconded by, I don't know that I heard who seconded.
Sorry, do we have a second?
And
The chair can second.
All right, I will second it in that case. And Debbie, would you please call the roll?
Roll call on the combined motion. Aye. Director Garza.
Aye.
Director Prendergast is absent. Director Story. Director Story. He must have stepped away. Chair Guggenheim.
Aye.
Aye, Debbie.
Oh, thank you very much. So Chair Guggenheim, you have 3 yays and 1 absent.
Okay, so the motion carries. And I believe we have now completed the agenda for this morning. And so I would like to remind you once again that the next meeting is on September 23rd, and now adjourn the meeting. Thank you all for your attendance.